So today I decided that I would give a brief talk on humanitarian anesthesia because more and more of us are getting involved in it in our department. There's a growing interest in this in the UW School of Medicine and Public Health, and more of our surgeons are beginning to do mission trips, and they're asking our colleagues to come along with us. And so I want to give an introduction to this because I think that as this program grows in our medical school, we'll see more people doing various trips. And I should say that the humanitarian trips that we do are clinical trips, but there can also be teaching educator trips, and there can be trips where you just go and lecture in these underdeveloped countries and essentially give these people the knowledge that you have expertise in that they are begging to get because they can't get it in their own countries. What is the mission of humanitarian anesthesia? It's to improve the availability and the quality of anesthesia care in developing countries through the training and the education of the local anesthesiologists, the anesthetists, and the anesthesia providers. These groups are also known in a lot of the literature as volunteer medical services abroad, or VMSA teams. And many of these surgical teams are made up of not just physicians from the United States, but they can be physicians from Europe, Canada, and a lot of the larger groups, for instance, the group I work with Resurge or Mercy Ships or Doctors Without Borders, are built up of teams that essentially come from developed countries that want to give some time back to places that need them. Regardless of the type of the surgery being performed, whether you're doing simple clubfoot corrections, some of the easier plastic surgery procedures, or whether you're doing spines and complex craniosynostosis, the main goal always has to be the safety of the child. And there are a lot of problems with practicing anesthesia in these countries that I'll get into that really provide the need for us to focus on that. You must do careful preoperative assessments of your patients and patient selection, the procedures, and you must know the equipment that you will have at the institutions that you go to and what you need to bring. What type of support and ancillary services are available to you, what type of postoperative care is available to you, and it's crucial for the provision of high quality care in the developing world. Now I want to talk about, there are actually a couple different philosophies about what we do on these missions, and I'm going to use the example of Smile Train versus Operation Smile. The Smile Train works with local physicians as a team, so they essentially set up a date to come. They've contacted the team in advance, and this team will work with them, both surgeons and anesthesiologists, in the operating room. They train local surgeons to carry out reconstructive plastic surgery procedures independently. And so basically, you're replacing the traditional medical mission with a more efficient and a less imperialistic system. And so far, Smile Train has trained, it's probably over 60 now, this data is 2 years old, local medical professionals now that can perform these operations independently without providers from the United States, Europe, or other developed countries. Operation Smile, on the other hand, sends a team of volunteers, and it's usually a big team of 40 or so individuals, and they basically close down the operating rooms in the places they go, and they basically fly in, push the local doctors to the sidelines, operate, and do as many patients as possible in the 1 to 2 week period that they're there, and they pack up and leave. There's two different thoughts to this. The first thought is that with Smile Train, you want to try to train people to become independent so that they can continue to do these surgeries and provide this type of care for these children in the country. With Operation Smile, their philosophy is that they at least can give these individuals that would never have the income or a chance to have these corrective surgeries, that surgery, and so they try to do as much bulk as they can in a week. And both services can be good, they're both safe. But the second one, Operation Smile, can be demoralizing to the local staff. They basically peer through the windows and they can look at your equipment and look at what you do and realize that they don't have the opportunity to learn or have a chance. And so personally, I prefer to work for groups where you teach and you can give something that hopefully will be able to improve the practice in that country when you're no longer able to get there. Just on the side about this, Operation Smile and Smile Train, early last year, and this was published in the New York Times, it was front page news, the two groups announced a merger. It was very surprising, and within 3 weeks it was aborted. The Smile Train donors that represented about 82 million in contributions signed a petition within a 2-week period that got back to Smile Train. The problem was that there was a problem with the financial deal that was set up. There were co-founders of Smile Train that fought with each other, and one wanted the merger, one didn't, and I think it was the reason for this was to try to push one of the co-founders out. But the main reason why it failed was because all of the groups, and it included institutions like ours, people like Mike Bentz and Del Mount, who have been Smile Train volunteers. They've gotten funding for several of our trips through Smile Train. And it basically got down to the philosophies because Operation Smile was going to take over and there wouldn't be training of other individuals anymore. I want to talk a little bit about medicine in underdeveloped countries and the characteristics of these countries and what makes our job so difficult when we go in. Many of these countries are characterized by poverty, poor housing and education standards, and they have limited health resources and social services. They're plagued by problems of undernutrition, infections, epidemics, poor sanitation, and contaminated drinking water. There's high rates of infectious diseases, HIV, malaria, and tuberculosis. And 70% of these nations and populations are located in sub-Saharan Africa. Correctable surgeries are conditions that account for approximately 11% of the world's disease burden. And it's estimated that in these underdeveloped countries, 85% of children require a surgery of some sort or another by their 15th birthday. And basically, it's because of congenital anomalies that make up a small proportion of this, but they're much more susceptible to trauma, fractures, burns, infections, and many of them often don't get the care for years and develop contractures and secondary causes for needing different types of surgery. The emphasis in these countries has been on preventative medicine. You get groups like the World Health Organization that come in and have done a lot of good, but they focus on immunization programs. They're aimed at prevention of communicable diseases, and these programs themselves are underfunded and poorly instituted. There's very little emphasis or money that's spent on curative medicine, such as the hospital services and surgical procedures that are needed. Central and state governments, a lot less and less funds to the health sector, and they're having problems with widespread access to care. It's really focused in the major cities in these countries. And the private sector hospitals focus on curative medicine, but they run with a profit motive. So basically, if you're a patient, you need to have money to have a corrective procedure. There's few institutions in these countries that run on charitable, that are able to sustain themselves with charitable donations. Edward Mills is the chair of the Global Health Department at the University of Ottawa, and he did a retrospective manpower analysis in 2011. And his quote was that developing countries are effectively paying to train their staff who then support the health services of developed countries. It's estimated that the cost of educating a doctor, or he estimated the cost of educating a doctor in 9 sub-Saharan countries, and he estimated the number of doctors that have been lost over the period of the last 15 years, and how much the origin countries paid in that time to train these doctors, and how much the destination countries saved by employing them. And in these 9 sub-Saharan African countries, that are most affected by HIV. There were more than $2 billion investment in training these physicians, because these physicians basically don't pay for their training. They're expected to work in hospitals they're assigned to when they're done. But many of them leave because, number one, they don't have the equipment or the facilities to practice in. And number two, they don't get the support or the equipment to be able to practice what they've trained in. The benefit to Britain has been about $2.7 billion. The United States, $850 million, and Australia has benefited by about $600, and Canada by $385 million by having these people essentially come and practice in our countries where they basically can get more recognition and more pay. So there's a critical shortage of trained manpower, an uneven distribution of providers. There's weak knowledge of the what they're practicing by the local providers. There's skill imbalances. There's poor work environments. There's lack of equipment, lack of support services. The physicians that are there are short-numbered, overstressed, and overstretched. And just to put up a chart of the countries that are in need of volunteer medical services right now, you can see that the majority of these lie in Asia and Africa and Latin America. But I just want to say that, as I said before, I think the highest need is in sub-Saharan Africa, and this would be Ethiopia, Kenya, Malawi, Nigeria, South Africa, Tanzania, Uganda, Zambia, and Zimbabwe. These countries contain 11% of the world's population. They have 24%, so a quarter of the global burden of disease, and they have 3% of healthcare workers. So the greatest challenge essentially is the scarcity and the lacking of funding, and how do we get this to these countries? How can they improve without it? These countries, as far as medical shortages, have an inconsistent oxygen supply and delivery. Some institutions have piped in oxygen, some depend on oxygen tanks, some don't get the weekly supply, some have no oxygen. There's erratic electrical supplies, and power outages are very common in these countries. Lack of running and water, uncontaminated water, makes for difficulty with the sterility for procedures in the surgical suites. There's shortage or a lack of up-to-date drugs and equipment. Monitoring in the operating rooms can often consist of one sphygmomanometer that's shared between operating rooms. So basically, essentially, they pass the one simple monitor they have around during the procedures in the operating room. Common anesthetic would be thiopental, which is actually being replaced by propofol. They're just starting to see the shortages now that we've seen in a couple of years there. And in Nicaragua, they still had pentothal this past fall when we were there. Ketamine is a common one because you can give it orally and not have the need for the airway equipment and anesthesia equipment that we have. Fentanyl, morphine, and pancuronium. And volatile anesthetics, up until a few years ago, halothane was one of the main volatile anesthetics that was used, and SIVO's actually pretty much taken over in most of the institutions, and a halothane has actually become a rarity. There's a lot of reuse of disposable equipment, endotracheal tubes, breathing circuits, gloves, even butterfly IV cannula are washed and reused. And lack of functioning, as I said before, of anesthesia monitors and patient monitors. If you look at the monitors on the left, a lot of you that have been practicing for a while will recognize the Dynamap and the Nellcor pulse oximeter. If I walk into an operating room to do a site visit and I see these, I actually have a sigh of relief, because these equipments are like our washers and dryer. They don't break down. So you know if you see them, you'll be able to at least get manual blood pressures and pulse oximetry. And these are substandard for us now. We've got advanced monitors that do the same thing, but over there it's a luxury to have these in the operating room. The slide on the right was one of Laura Hamill's slides from a trip that she had done to Guatemala, and I would just make a quick plea that if you do these trips, the one thing that you need to look for on your machines is the scavenged gas and where does it go. Nobody, or it's very rare that in these countries that they scavenge gas. It usually just ends up going into the room that you're working in. Done a couple trips where our team has felt sick and we've realized that the hose has fallen out of the window. We've had to set up our own hoses to scavenge that we run out into the hallway because we don't want to be exposed to it, but there's no other place to run it, and that's where they run it for us. So I think you always have to be prepared to look at your equipment very carefully. And they're very good at essentially coming up with, as they said in the newspaper, MacGyver techniques to basically equip you for what you need in a matter of minutes or a day. Most anesthetics are provided by non-physicians in these countries. There can be anesthetists that work independently, and in the rural areas that's typically the case, but even more so, there can be trained on the job nurses or field workers who have been brought in, trained some of the basics, and are expected to give the anesthetics. When I went to Uganda with Benny in the operating rooms that we worked in there, we had workers that were taken right off the street. They essentially were some of the road crews that were brought in. They were trained to be scrub techs. We actually had nurse anesthetists that worked with us there. But in many institutions, it can just be an RN that's had just very little training, trained by their surgeon as far as what drugs to give and how to monitor patients. In 1998, there was a survey in sub-Saharan Africa. It was 13 countries and a population of almost 100 million people. And in that area, there were only 122 anesthesiologist physicians. There were 868 anesthesia nurses, and most of them worked in the capital cities. There were no physicians that worked outside of the major cities. Again, in Uganda, when I visited it, we worked in one hospital in Mbale. There were 5 hospitals in the city. We did have one anesthesiologist who would rotate through in the morning and discuss cases with the nurse anesthetist, but basically he was there for probably the first hour of the day and left, and that's his day. Typically he rotates around to the 5 hospitals, and that's the expectation for him. A subspecialized anesthesiologist is a luxury, and many of you met Dr. Cynthia Lole, who was the Ugandan anesthesiologist that worked with us for 6 months. She actually was trained in the largest city in Kampala in Uganda, went to medical school, and then actually had pediatric training too. So she is considered a commodity back in Uganda where she works. The most common anesthetic technique that you see is general anesthesia with volatile anesthetics, and patients usually are kept spontaneous ventilation or manually ventilated by hand. And this is because basically most of the ventilators are broken or they don't have the paralytics that they need. And the other thing is that typically in a lot of these institutions there's no recovery rooms. The family does the recovery, and so you want to try to essentially avoid anesthetics where you're going to have a lot of postoperative respiratory depression. As I said before, ketamine is used in many of the very rural areas, and for children it's often seen. Again, it's easy because you can give it orally. You can throw essentially a monitor, basically just look at the child and watch respirations while the surgeon operates. They have lack of airway equipment. Sometimes there's lack of even IV cannulas, and so they rely on just oral sedation for these procedures. They do use regional anesthesia techniques, and the regional anesthesia is really growing in these areas. They feel that this decreases the morbidity, mortality by avoiding the general anesthesia. And general anesthesia, the risks of aspiration, the risks of having patients with decreased blood pressures and cardiac arrest because of the inability to monitor oxygen saturation and blood pressures is much higher. And with regional techniques, the patient can be awake and can be talking to them. They can do these procedures then and have little respiratory depression unless they get a high spinal, and that's one of the complications that's seen in the QI data that I talk about later. It might be the only choice of anesthesia in some of these locations due to the lack of the equipment and the lack of drugs, volatile anesthetics, induction drugs. And in some areas, neonatal surgeries performed because of the high risk of doing these babies simply under local infiltration to avoid or improve the outcomes. There's limitations to this, obviously, because of the lack of expertise and the lack of equipment to do these blocks. They don't, in many areas, have the nerve stimulators and the ultrasounds that are now common for us and we would consider standard of care. However, some institutions, I was surprised, do have these things. I did a teaching trip to Mali 2 years ago, and I had to give a few lectures on anesthesia for upper extremity surgeries. And basically these were machete accidents or burn injuries, and this was what the hospital was focusing on. And I went with one other surgeon from the interplast group. And when I wrote my talk, I thought, well, I'll focus on nerve stimulator, and I'll donate a nerve stimulator, and I can talk about the risks and benefits. And I got there, and there was a German anesthesiologist who essentially had met her husband, who was from Mali, on a rotation when he had come to Germany, and was very well trained, and actually had brought ultrasound technique to their hospital. So they were very knowledgeable and actually could do a block very quickly with ultrasound of the upper extremity. So it was kind of fun to be able to watch them do that. I just want to point this out. This is Rogelio. Rogelio is the anesthesiologist that we work with when we go to Nicaragua, and spinal anesthesia is generally the type of care that's provided for most of the C-sections and deliveries in the hospitals. There have to be mutually cleared goals between your group that's coming over and the group that you're working with in the underdeveloped country. And both the host and the visiting team have to have a full understanding and agreement of the purpose of and the mission, the goals, and the program that's going to be delivered. You have to communicate and discuss in advance, will this be a teaching trip? Will you basically just provide surgical services and teach while you're in the operating room, or will it be a combination of both? You have to understand the expected level of the visitor and the host involvement. How many people will you bring? Will you expect that you will have ancillary help? When we do a lot of these trips, the surgeons are working with surgeons over there, but will there be an anesthesiologist that's interested in coming in to work with us and to learn, that can provide these services for these patients after we leave? Will there be intensivists that come over to look at the patients and anybody that will be able to take care of these patients post-op? What type of procedures are being performed? Will they be complex or simple? And what types of equipment and services will be available to you there, and what do you need to bring? All needs to be figured out in advance. And also, what types of patients are you going to care for, pediatric or adult, ASA 1 or 3? This is important because this essentially determines the type of equipment that you need and what you need to pack to go on these trips. And the other question you have to ask, are there any other surgical groups that are providing similar care? Because if there are, you can essentially get to these areas and find that you don't have a lot of cases to do, that essentially the Swiss team has come in the 2 weeks before and has done the majority of the cleft palates. And if you don't plan your trip timing right, you essentially may not be able to treat the patients and give them the most benefit. Prior to any mission, a site visit needs to be done. And you need to know in advance, again, several different questions that have to be answered. Is there adequate space in the facilities? What equipment is available? What are the anesthesia machines and monitors like? Will you be able to work with them, or do you need to bring your own? What types of equipment is available for the surgeons, such as suction, Bovie, etc.? If it's not available, you've got to bring it or you can't do the cases. Again, adequate ancillary services. If you're doing the larger procedures, is there a lab in the hospital? Is there a blood bank, or do they depend on the blood bank that is 5 miles down the road? Is there radiology services? Can drugs, IV fluids, and supplies be purchased on the spot? And this is important because basically if you need to bring all of your IV supplies, that's a lot of weight and a lot of bulk, and it's much easier to buy these things when you get to the country. Are there any other, we talked about before the other surgical groups that are providing services, and then the logistics. Will there be adequate transportation, housing, and food for your group in the town that you work in? Is there dependable electrical power? What types of oxygen supply? All important to know in advance, especially if you're bringing your own portable anesthesia machines. You need to make sure that you're going to be able to hook up to their oxygen supplies. And I've been on several trips where we've had to MacGyver the oxygen connectors because essentially they're not the same as the ones that we use in the United States. What's the post-operative care like? This is very important. Is there even a recovery room in this institution or not? If not, you could consider bringing extra nursing support to take care of these patients post-operative. And then political, do you have government approval for this? And that's essentially very important before you come into these countries. And are the countries safe, and what's the security like for you when you get there? As far as team housing, you don't stay at the Four Seasons when you do these trips. And essentially you've got to find a place where you can where your team can wash and where they can eat a safe meal and not have to worry about the risk of salmonella. These are examples of the types of places that we stay in Nicaragua. When we work in Leon, we essentially stay 20 miles away. It's actually a beach bungalow. It's a cinder block house with about 5 or 6 rooms that have 3 or 4 cots in each room, and 2 showers to be shared with a team of about 10. And essentially that's our living space. When we work in Matagalpa, we actually stay on a coffee plantation, Selva Negra, and live in a bungalow that again has 5 or 6 bedrooms and 2 showers. Oops. Surgical teams operating in the developing world have to expect to provide all the essential equipment, and you have to reuse disposable items. You're not going to be able to get through a trip to be able to pack everything you need for the types of cases without reusing things. And basically it's because you don't know the ages or the types of patients that you're caring for until you get through and you do the clinic. You've got to pack everything because essentially this is what their blue cart looks like. And they have all the essentials. Looks like they've got a radio. They've got pentothal and succinylcholine. They've got halothane, and they've got endotracheal tubes. So they've got everything that you would need to do a procedure there. So know your equipment, do the site visit in advance. What do you need to have? Again, you need a modern functioning anesthesia machine with a calibrated vaporizer. You need monitors. Essentially, we want to be able to teach them the same ASA standards that we have. So if places don't have pulse oximetry, you need to bring a pulse oximeter. You want to be able to take blood pressures and take temperature. We don't always have the luxury of watching EKG. Some trips we don't have the portable monitoring to be able to do this, and the equipment that was promised isn't there. Oxygen supply, airway equipment, vacuums and suctions, stethoscopes, syringes, all your disposables, your anesthetics, your antibiotics, emergency medicines, and then depending on the type of cases that you do, if you're doing more complex cases, do you need to have an iStat lab, a defibrillator, and infusion pumps. I'm not going to go through this list, but this is essentially the list that I've created that we need. It's a checklist, and we take all of this equipment. This would be for a 40 patient simple plastic surgery trip. It can be tailored to adult patients, and Misha actually has taken the list and tailors it for adults for ENT trips. And it can be tailored towards more complex cases, cardiac cases and spine cases. You need to add in the additional monitoring equipment, pumps, and drugs that you would need for these cases. Hardware, laryngoscopes, all of these things we pack to take. Oral airways, nasal airways, the disposables, all the endotracheal tubes, both ray and regular endotracheal tubes, depending on the types of cases you're doing. Breathing circuits, face masks, IV administration sets, needles, syringes, tapes and tourniquets, pens and pencils. Basic, simple things. You've got to think about everything, because if you get there and you don't have it, you won't get it. As far as drugs go, we take resuscitation drugs, neuromuscular blockers, although we try to shy away from neuromuscular blockade. Analgesics, they can be kind of complicated. Sometimes it's hard to take narcotics into certain countries, and you definitely don't want to try to take them out and bring them back to the United States. You can get yourself in some trouble for that. Antiemetics, anesthetics, local anesthetics, and antibiotics. You've really got to plan to sort of know your patient population and what you need, because often you run low. I have created a couple of hardware kits that anybody that takes these trips can take with them. This is thanks to the grant money that Dr. Pierce and our department's given us, but basically I've built a blue cart into two supply kits, tool chests that can be taken as luggage, and this has all of the hardware needs for basic procedures. All of this is reusable equipment. It all needs to be brought back, and there is a checklist in this box. I just want to show, this is essentially an anesthesia machine that we use on the research trips that I do. And it's a basic machine. It comes in about 10 different pieces, and I can put it together in about 15 minutes. But this assures us that we are giving calibrated anesthetics and volatile anesthetics to our kids when we're overseas. And you have your fresh gas flow in, your flow meters and regulators, your essentially your volatile anesthetics, your CO2 absorber. And we use a King system circuit, so essentially, you know, hook up to here, and that's what we depend on for these types of procedures. In most of the trips that I've done that are based, the UW-based trips, we don't have the luxury of having these anesthesia machines, so you have to depend on what you know about the equipment that's in the countries that you go to. This would be the ideal volunteer surgical team makeup, and there are a couple published papers on this. And this would be to run 2 tables, so essentially 2 operating rooms. And I say 2 tables because it's not always 2 rooms. Sometimes you're running 2 tables in 1 room. But 2 to 3 surgeons, typically it's 2 for 2 tables. 3 anesthesia providers is ideal. If you can have more, it's a luxury, but 3 is a necessity because you always want to have an out person who can assist with inductions and intubations and emergencies in the 2 rooms that are running. Or if there's an emergency, it can be an extra hand. And then when they're out, they're actually also washing the equipment that you're going to have to use for the next case. 2 circulating nurses, 2 scrub techs, 2 PACU nurses, and either a pediatrician or intensivist who's actually taking care of these patients on the ward while you're in the operating room working. And it's essential to have interpreters on these trips. You've got to have somebody that can communicate. Often on these trips, if you're working with some of the international or the national groups, you're meeting your team members for the first time in the airport on day 1, either at the airport to travel over, or you meet them in the host country when you're trying to catch the bus to the hospital, or essentially loading up all of your equipment. Team members are together 24/7 on these trips. You basically travel, you work, you lodge, and you eat together all day for as long as the trip goes, so that you have to get along. There can be team member burnout, and if individuals don't get along or there's a problem, it needs to be discussed right away because it can really ruin a trip. And I've been on 1 or 2 trips where we've had personnel issues. It's not fun. Clinics usually happens on your first day. Typically what happens is there is a notice that's sent out, either local in the village that you're working in, but typically it gets out and word of mouth gets out across the country, and you can have people traveling from surrounding countries. They can travel for miles, and some patients say that it takes them 2 days to get there, but these are patients and families that know that without your care, that you're essentially providing them for free, they would never get these services. So clinics are usually overwhelming. You can see 200 patients, and your clinic usually starts at 8 in the morning and often can run until 7 or 8 o'clock at night till you see the last patients. These patients won't leave. They'll sit there for 10 hours until you see them. And typically what happens in a clinic is you set up stations. They'll go through the surgeons stationed first. They'll be essentially screened as to whether they're appropriate for the types of procedures that we're offering them. They'll come and see anesthesia and the pediatrician or the intensivist next, essentially to be ruled in for surgery. And then they'll see the nurses and have their crits checked, their glucose checked, and all the paperwork completed. These are a couple examples of some of the different clinics that I've been to. Preoperative assessment's a key. You've got to do a thorough history and physical. Often this is the first time that these children or adults are being seen by a physician. And so you've got to rule out everything. Essentially, you're not just being an anesthesiologist. Many times you're being an internist too. Are you doing pediatric versus adult population? What's their ASA? Do they have coexisting disease? What are the airway abnormalities that you might have problems with? We don't take bronchoscopes on these trips, and occasionally we'll take a glide scope, but basically you've got to make sure that you do a thorough examination. Syndromes can be common, especially if you're doing plastic surgery, cleft palate trips, because there's many associated syndromes, many of them associated with airway difficulties, Pierre-Robin, Treacher-Collins, Turner's, Apert's, Pfeiffer's, Klippel-Fell. You've got to really look at these kids closely. Often these children have chronic respiratory symptoms, cough, bronchitis, because their families are dependent on cooking over open flame or heating their households at night with fires, and because of pollution in the country. So these kids can have a lot of problems with bronchospasm, laryngospasm in the operating room. Children can be small for their age. They have poor nutritional status. They're malnourished. They have limited glycogen reserves. Because of this, essentially they can get hypoglycemic very easily in the operating room. If you have a child that doesn't wake up at the end of your procedure, one of the first things to rule out is hypoglycemia. Give them a little glucose. I've seen miracles happen at the end of cases where we're very worried about children, and it's just because their glucose was probably 20 or 30. The kids are dehydrated. They have an advanced state of their surgical condition. Usually they don't present until a very late stage, and so that makes the procedure a lot more complex, more difficult, and it can make your essentially management of the airway in some cases a lot more difficult. MPO status, we follow the same ASA guidelines, but I can tell you that parents will lie. They'll tell you anything because they want their child to be operated on, and there can be a language barrier. They don't understand the MPO status. So preoperative assessment's important. Common infectious diseases that you see, HIV, if you're working over in the African nations, is very prevalent. It's estimated that 33 million people are living with it, and essentially 26 million of these are in the sub-Saharan African countries where you're working. The treatment, essentially the coverage of treatment has increased 41% from what it was 10 years before 2010, and approximately 50% of women now are at least getting some HIV care, but 48% of the blood donations in these low-income countries essentially don't screen. And, 48% now have quality measures, so 52% don't screen. And many of these children or adults need blood for malaria. And so there's a prevalency of HIV in the country. Tuberculosis is also quite common. There's a reemergence in these countries because of HIV and immunosuppressed patients. And so basically a cough, chest cavitation on chest x-ray, you've got to rule this out. Malaria, malaria got its name because it was thought that it was contacted in the swamps. It can be. It's transmitted by mosquitoes, but that's how it got the name malaria. This affects 300 to 500 million a year, and basically is a parasite, gets into the blood via the bite of a mosquito. And essentially, it's a 5 to 30 day incubation period, but it can be transmitted from patient to patient because of dirty needles or because of essentially the mosquito. And this is something that healthcare workers have to make sure that they're prepared to take prophylaxis for this when they go into these countries, because you're at risk to develop it. Hepatitis C, blood transfusions, the major cause of this. And again, now patients that essentially have malaria, drop their crits below 25 and get transfusions are contacting hepatitis C through the blood transfusions that they're getting to treat their malaria. So this is a growing epidemic. And typhoid, essentially bacterial infections from fecal contamination of water is very common too. Parasitic infections are present, and you basically have to keep them in the back of your mind. You don't see them often in the patients, but you yourself have to worry about these type of things if you're swimming in these lakes in these countries. So an estimated 70%, as I said, of all blood transfusions in Africa are given to children that have severe anemia by malaria, and less than 30% of them have nationally coordinated blood transfusion services. Many of these blood banks don't do the testing for hepatitis B, HIV, Hep C, and lack equipment. A lot of countries rely on essentially a member of the family to donate blood for procedures before they will take either children or other family members to the operating room. So patient selection, patients are considered complex for these cases if they're less than 1, if their ASA status is greater than 3, hemoglobin's less than 10, significant airway abnormalities, poor nutrition, or complex procedures with potential for large blood loss. If there's any question that a particular procedure to be performed is unsafe or the patient has significant risk, don't do it. Don't do it over there because you'll get yourself into trouble. A couple examples of advanced disease states that potentially you can see on these trips. These are all patients that I've seen. This child, unfortunately, I said was too high of a risk. The child couldn't even open their mouth. Sad, but you have to essentially do what is best, and sometimes it's best to just rule out taking these children or adults to the operating room. Burn contractures of the head and neck. You really have to pay attention to airway exam for these. You can have lots of problems with them not being able to extend or open their mouth. So the problem is that you're caring for a very large number of patients. Typically in a week you can do 45 to 60 cases and double that if you're there for 2 weeks. You have to have efficient patient screening, rapid OR turnovers, short patient recoveries, and optimal post-operative patient stability. Typically on day 1, you meet with your host and the physicians and administrators and discuss the types of procedures you're going to do. You send half of your group to clinic and the other half to the operating room for operating room setup. Locate the hospital lab and blood bank and make sure that that's all set up in advance before you start. And have a team meeting prior to the first procedure to basically run through some emergency scenarios and talk about the safety precautions that you have. Again, with the operating room, intraoperatively, you can have a 2-table setup in one room. This has the advantages of letting the whole team be in one room together. If there's an emergency on one table, you've got a hand right next door that can help out. Staggered procedure starts are a must, and the most difficult cases shouldn't be the first cases you do, and they shouldn't be the last cases you do before you leave the country. Anesthetic techniques, we really use minimal or no preoperative pre-medications, and we rely a lot on regional anesthesia because essentially you're minimalizing the amount of narcotics that you need to give for postoperative pain. You're minimalizing the potential for respiratory depression. So the best and most successful trips are mission educator trips. Training a new generation of teachers is a key to building more effective training in anesthesia throughout the world, and the goal is to improve the availability and the quality of anesthesia. And you essentially want to go as a trainer, but you want to become a reference. You want these people to work independently and be able to email or call, but the goal is to get these people to be able to do what you do. You need to train the trainers. And this is a picture from our trip in Nicaragua. We actually took a glide scope and we taught them how to use this, and we worked with these. This is in Leon, so they actually have a training program, and these are anesthesia residents that we were working with, and they didn't have Eschmann stylets. We left several and trained them on the use of these. But the goal is to teach them something, give them something every time you go. It's good on these trips to essentially plan for some downtime for either a workshop or lecture time so that you can essentially give them some extra education outside of the operating room also. And these are your teachers that are here. We have several now that essentially work on these trips and can be a good reference to anybody that decides that they want to do this is going for a first time. Post-operative care, very briefly. As I said before, there are not a lot of recovery rooms, and the surgical wards are often crammed. Sometimes several families will share 1 or 2 beds or sleep with their mats on the floor. The families are responsible to bring in all the dressing changes, equipment that are needed, and all the food for these patients. There isn't a hospital service that does this. Just a little bit about morbidity and mortality. Quentin Fisher reported the first large-scale cohort analysis of anesthetic outcomes. This is from a volunteer surgical program. This is from Operation Smile. Data was taken from surgeries over an 18-month period. There was a retrospective analysis of 6,000 patients that were cared for, and basically they looked at roughly a little over 5,000 that had general anesthesia. The surgery procedures that Operation Smile does are typically plastic reconstructive, so burn reconstruction of cleft palates, and 95% or 1.8% had significant negative events, and this is in comparison to the data from Canada, the US, and Europe, where the approximate ranges for this are 0.04 to 0.6%. So basically, this is not a team from these countries. This is essentially a developed team that goes in, but still, because of the conditions that you're working on there, has a risk that can be anywhere from 3 to 15 times higher than what we have in this country. The types of events that they reported were returns to the operating room, intraoperative reintubations, postoperative reintubations, the need for unexpected blood transfusions, malignant hyperthermia alerts. There were none, but there were alerts for it. Negative pulmonary pressure edema, CPR death, obstruction due to retained throat pack, which can be common on some of these trips for pallets, and resuscitation for hypotension. There was a survey from Cameroon, and this is now the locals. They looked at the locals that are working. They reported a perioperative mortality rate of 2.45%, and common causes were hypoxia, aspiration right after induction typically, hypovolemic shock, and extensive sympathectomy following a spinal. There's no data on the incidence of problems that are associated with anesthesia that's provided by non-physician providers. It's just not out there. What are the major contributions? Again, lack of functioning, good equipment and monitors to take care of these patients, severe shortages of trained providers, and exaggerated disease states. So it's strongly recommended that mission trips from here that go have some type of quality improvement data. They keep track of the events, critical events that would happen, such as cardiac failure, respiratory arrest, or death, anesthetic complications, failed intubation, bronchospasm, the need for reintubation, essentially wrong drugs used or given, and the surgical complications such as wound infection, dehiscence, because these are all things that can be correctable. What are some of the barriers that we have to practicing? Language barriers. Again, we talked about broken or damaged equipment, contaminated water supplies, contaminated food. Typically, boiled drinks and bottled drinks are safe, so usually the coffee and the beer is good. Exposure to infectious diseases for the healthcare workers on our team that are going. This actually is a picture of a patient that was ruled out by the locals. That's a big cavitation. This patient came in with a cough and had TB, didn't get their corrective procedure by our team. Political unrest, weather problems. I've been in Nicaragua during hurricane season, and that's caused some havoc. Transportation, the infrastructures, the roads aren't always the best. There can be flooding. Travel by airplanes to some of the rural areas can be risky. And a lot of times our transportation is in the back of the ambulance, the back of a truck. And team member burnout. Essentially, you've got to have some downtime. There we go. Not working in the operating room. You can't go in to work in the operating rooms at 7 a.m. every morning and get done at 10 o'clock at night. After about 3 or 4 days of this, the team burns out. Customs can be a problem getting your equipment and your drugs through, and there's cultural barriers. Travel basics, this is just some extra tools, and people can talk to me if they do these trips, but essentially currency information, weather, world travel guide, language tools such as Yahoo Babelfish is a good translator. The Spanish Dict is a good one that you can get, and Rosetta Stone. Custom guidelines, essentially know the customs in the countries that you're going to, know the country profiles, and essentially know the security information about these countries before they go. Are they high-risk countries? Are there terrorist problems in these countries? You typically wouldn't want to practice in these areas, but when we practiced in Mali, there were terrorists in the northern parts of that country, so we had to essentially move as a group and always stay together. Some of the health-related links, the CDC's got a great link if you go that you can pull up, and essentially this will give you guidance for the types of immunizations that you need before you go to different countries. Our department offers several trips to residents. Residents have to be senior residents, and they have opportunities to go on anywhere from a 1 to 4 week trip, depending on what they plan. Essentially, we have a group that goes, a PEDS plastic surgery group that goes down to Nicaragua. There's a cardiac surgery mission trip, heart-to-heart mission, that practices in Santiago, Dominican Republic. Faith in Practice is a group that Laura Hamill works with. They practice in Guatemala, do several different types of procedures, GU, gyne, ortho. Her next mission is February 25th. If there's a senior resident that's interested, they can have a talk with her about that trip. And the UW-ENT trip to Honduras that Misha now runs, practices based in La Ceiba. And this is, it's a pediatric and adult, probably more focused on adult ENT trip. As far as coverage, there is professional liability coverage through the medical school if you work for the medical school, and you need to get approval from your department chair or from the dean before you do these trips. There's also automatic evacuation and repatriation insurance coverage through MedEx, and you need to set this up through the Office of Risk Management. You should contact them in advance before doing these trips. They'll give you a MedEx card. And the medical costs that are incurred on these trips aren't covered, though. You've got to have your own insurance for that. You can get all the policies off of the UW Center for Global Health. Why be a humanitarian physician? Basically to provide surgical services to children and adults that probably otherwise wouldn't get it, to be able to provide education in the field of anesthesia in resource-poor countries, to basically provide medical care with the humanitarian principles and the medical ethics and impartiality. Basically a commitment to bringing quality medical care to patients in need regardless of their race, their religion, or their political affiliations. You do this to develop international associations. You do it for self-gratification. Essentially, these are some of my favorite vacations to take. And these are other reasons why we do these trips. Resource organizations, the ASA, Global Humanitarian Outreach, the World Federation's Society of Anesthesiologists, the American College of Surgeons has Operation Giving Back, which has lots of resource information, the World Health Organization, and as I said before, our UW School of Medicine and Public Health Center for Global Health has a lot of information on their website, and the CDC. I just want to give teacher recognition to the teachers that taught me. Two teachers, Nancy France and Les Proctor, were physicians that worked here. And George Gregory, who wrote the textbook, I've done a couple trips with him, is phenomenal. The work's hard, take time to relax. I've been told by some of the surgeons I went with that essentially these are good residency recruitment pictures for our department. Visit church on Sunday. Sunday is usually a down day if you're there, and the churches have some of the best architecture and art that you can find in these countries. And get involved. That's it.